before we start proceedings, may I bring to your attention to some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing by entering the Warspout room. Committee members are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Can I please ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you're not using it. Your mobile devices are turned to silent. Item 1, apologies. Elliot.
Thank you, Chair. No apologies for today's meeting.
Item 2, declarations of interest. Is there any declarations of interest today?
I'm an employee of University Hospitals Trust Plymouth.
I work for NHSP.
I'm an employee of UHP Plymouth.
Yeah, noted. Thank you, Chair. Personal interest. Won't be making any decisions on that today, likely.
Item 3, minutes. To approve the minutes of the meeting held on the 21st of November. Any amendments? Oh, Mary?
I'm 99% sure that I was there at that meeting, but I'm not down on your in attendance list. All right. I think I was there. Yeah.
Thank you, Chair. We'll add that to the list.
Any other amendments? No. Can I have a proposer? Councillor Lugger, seconder. Thank you very much, Councillor Moore. Moving on. Chair's urgent business. I haven't got any urgent business, but I need to bring up about reports. I understand that Elliot has really struggled to get reports sent this time, and it's very unfair that we get an officer having to keep chasing for reports. I mean, we actually only received one report yesterday, which isn't good enough. What I'm not going to accept this year, if I'm still chair, that Elliot keeps having to chase for you for reports. If you don't submit them to him when he's asked, we will come to this meeting without those reports presented to us, and then you will have to answer why those reports have not been given to us. Is that okay? And I mean that's NHS, that's do you know what I mean? It's our partners, it's internal, it's PCC, it's not just, that's everybody. But I have felt really sorry for Elliot this time. Not only has he had this scrutiny, but he's also had budget scrutiny. There was full council yesterday, but he's had to chase for reports for today, and I'm not accepting that anymore. Mary.
Thank you, Chair. And yes, I would totally agree. It's not acceptable. And I think Gary and I will do some work on this to make sure people understand. There has been some changes in staff, so it may well be that they don't quite know when Elliot sends them a date, that's the date it needs to be. So we will chase that. Thank you. And sorry about that, Chair.
That's fine. This isn't the first time I've had to bring this up as an issue. I had to bring this up before, and I just feel we're being very, very unfair. And I understand pressures of what officers have got, and I do get that. But you are given enough notice to get these reports together. So I will not be accepting that anymore. So thank you. Item 5, finance report. Rebecca, thank you.
Good afternoon, everyone. For month 8, the Adults, Health and Communities Directorate reported a 4.4 million overspend, of which 2.4 related just to adult social care. The main pressures are consistent with what we've seen throughout the year, so a rise in the demand for domiciliary care. A reduction in the wait list has led to more pressure coming into the system. We have offset this slightly. We have additional joint funding and client income to help reduce that expenditure. We've had some inflationary pressures following the collapse of our previous provider for community equipment service. Money needed to be put back in to ensure delivery of that service. And of course, we've had actions going on in the background to help mitigate this. We've had our budget containment group activated from the beginning of the year and ongoing work groups to help identify the high risk areas, what we can possibly do to reduce spend, to increase income and offset those pressures. Part of that work has produced 800,000 additional income from health by identifying some domiciliary care that we can recharge to our health partners. There are still risks in the background. We have delivery plans of 500,000 that we've brought forward from previous years that are still in progress. We have achieved 2.7 to date, the 25-26 delivery plans in full. And our budget for next year was being done alongside that. We have a growth of 11.1 million for next year, so that will be to cover both our national living wage pressures, our inflationary pressures, and to meet some of the demand pressures we've seen in next year that we expect to continue throughout the system. Any questions?
Andy?
Thank you. Before I ask the question, I totally agree with your observations on papers coming in late, Chair. When I was Chair of Audit Governance, that was the bane of my life. Anyway, a couple of questions. Thank you for the report. I see that you have a degree of budget containment, which has made net savings, quite considerable savings against the overspend in many respects. And this is by charging elements of domiciliary care to the ICB. I mean, it's pity we can't charge many more things to the ICB, but in the short term, is there any further work that can be done on reducing costs in that way? Thank you.
I'm happy for the service to focus on the work.
Yeah, thank you. The potentially is, I think, the important bit is to make sure that the right service is accountable for the right level, the right amount of care. So if the person's receiving health care, health are funding that, and if the person's receiving social care, we are accountable for what we are delivering. And that's where that movement of money has taken place, where we have uncovered that some of the one-to-one support that we've been providing for people, much needed support, but actually is health support, because it's to support them in those initial days when they first leave hospital. So there is some potential in there, and we're making some changes to some of our practice in order to make sure that we realign that. And moving forwards, we won't have such a big sway either way, which will benefit the person and both budgets.
Anybody else got any questions? No. I mean, obviously, for us who sat on budget scrutiny, we would have heard anyway. So I'm quite happy to. Lauren, if you got no, I'm quite happy for us to move on. So thank you and welcome. And I'm really sorry if it felt that I was getting at anybody, but I reports really need to be on time.
It's a completely fair point, and I can apologise if there's been delays. Obviously, we are working to make sure we snip any problems in there.
Thank you, Rebecca. Item 6, adult social care performance monitoring report. I've got Julia, Jill, and Ian. I've got no Andy. Is that right? Okay. Thank you.
Thank you. Are we okay to share the slides on the screen, please?
Can you start without the slides now?
Yeah,
Is that okay?
Yeah, no, of course I can do. So slide 1 is our usual overview of our performance, and then slide 2, moving on fairly rapidly to the actual detail, but this is just as a bit of a reminder about our vision for adult social care and our 4 key areas of work. Slide 3 is a kind of slightly cheeky reminder that we are going to be talking about our CQC inspection, and just to kind of keep everybody minded that we did achieve a good, which we're incredibly proud of, but we'll come on to that a bit later. So the next slide, so yeah, that's great, thank you, whoever's doing that.
Yep.
Next slide is
I'll
Ian.
jump in.
Yeah.
So, to allow room for questions, I won't go into lots of detail on the slides. I'll just kind of cover the main points. So, mostly this is good news, and for those of you who've been attending for a while, you'll have seen the journey that we've been on. So, the headlines for me are: there's nobody now waiting for longer than 5 days for the initial triage. So that's the first point of contact to making a decision about whether somebody needs a more comprehensive assessment or not, which is really good. That means lots more people are now getting advice, signposting the information at a much more earlier point if they don't need that care assessment. So that's the first bit, positive news. The second bit is we are making good progress towards our target around Care Act assessment timeframes. We aren't there yet, but we've come down from well over 200 days and we're on our way to hitting the 100-day target. And then the third bit of good news is from an unacceptable high. We all agreed that some people waiting over 500 days, that number's also come down now significantly. So overall, good progress. The other thing just to add is for those people that are waiting, as a reminder, we have our waiting well policy fully implemented, which means people have got that proactive contact while they're waiting and they know who to contact if things change for them. So those were the three bits I was going to pull out from that particular deck. I think it might be me again next for the review slide. Or is
That's me.
Oh, sorry. Apologies.
Sure. Thank you. So next slide, please. So this slide represents our review. So when people have been receiving care, to going in and ensuring that we are completing a timely review to check that if they still need that level of care or not. You'll see in here that there has been a slight reduction in the number of people, a number of reviews that we've completed. But on looking into this, we've done a lot of targeted review work. So really making sure we're prioritising risk over people who have just been waiting the longest, and those of high risk we have been seeing. Because we've been completing proportionate reviews, so only doing what we need to really do for people and with people, we recognise that we're not always capturing the data in the right way. So we expect to see some significant changes in this report moving forward because of how we will be changing how we're collecting some of our data, if that makes sense. So we're reducing packages where people don't need it, in essence, which is a good thing, helps to improve people's independence, and is the right thing for people. Do you want to say more on that one?
Just only very quickly, just to make a link back to the finance discussion, some of that review activity is also for people who we think could be eligible for continuing healthcare. And we've seen some trend shifts in that over the sort of recent period. So that's also accounts for some of that proactive targeting review activity to make sure that people are being funded through the appropriate stream, as Julia said.
Thank you. Can we have the next slide, please? So our occupational therapy waits and these pressures still remain a significant priority for us. There is some, and it's really a reminder that this is a combined waiting list across both adult social care and health referrals for occupational therapy. The picture is improving. We have only 18% of these people have been waiting for over 300 days. We recognise that that is still too long to be waiting for assessment. So Ian and I have agreed a significant review of our adult social care activity to really describe a much clearer definition of adult social care, occupational therapy, as opposed to health, rehabilitation and occupational therapy. We've also, as Ian's spoken about before, implemented a waiting well. So we're contacting people, we know people are safe, but we absolutely recognise this is still unacceptable length of time for people to be waiting. So we have agreed to do a significant review of that piece of work across PCC and Live Well South West.
Chair, can I just suggest it might be useful if Julia explains what Section 2 and Section 9, because obviously that's differentiated there.
So Section 2 is the more preventative work that people are coming to us with support with, and section 9 is where we are really completing a full assessment of their needs. So obviously looking at this information, the large majority of people are coming at the preventative stage, which we would really like to get to and support people, because it will stop them slipping into requires some additional support. Next slide, please. So this represents our residential and nursing care numbers, and the overall numbers have remained stable throughout November and into, obviously this is December's information. Our care home framework went live at the beginning of January. This means that we have a more collaborative approach with our provider market to support the cost of care, but also in the work and the interventions that they're providing for our citizens. The two numbers at the top are reflective of the flow, and the two numbers at the bottom are national metrics, which are per 100,000 of the population. And I know they can seem a bit confusing how we're presenting those. I'm happy to make some amendments to this report moving forward if they are a bit more confusing. Next slide, please.
I have got Councillor Lugger, but I was going to wait until the very end, if that's all right with you, Angela, so that you can present the slides and then we can ask questions after. Is that okay? Thank you.
Thank you. So the next slide is our December data, and we anticipate this is a trend that will continue. We have a slight reduction in the number of people who are receiving domiciliary care, and however, the number of new packages starting each month does tend to fluctuate. We're working with our market to ensure we've got capacity, to ensure that there are enough resources to meet the current demand and the future demands that we are predicting. Next slide, please. So our reopenment performance was stable in December, with our over the target of 80%, but over 81.8% of people are remaining at home 91 days after discharge. The note on that is that the national target has changed recently and is now 83.9% of people should still remain at home following discharge from hospital. We will be reporting on that number in April, so it's really just the figures might change slightly and our trajectory might change a little, but this still remains a service which we're incredibly proud of, and it's achieving good outcomes for people and supporting them to remain at home for longer. Next slide, please. So a good news story for people receiving direct payments. We now have the service in-house, and we're seeing a steady increase of people who are choosing to manage their own services and their own care. Better for people, better outcomes, and just an improved picture in terms of the flexibility that the market can provide. We're doing some work with training our staff to making sure that they're offering direct payments to people as a first port of call. So this is a really improved picture, particularly when we had the blip over the summer. So next slide, please.
Yeah, so the information in the top right box, just to remind people of what acronyms mean. The NCTR is no criteria to reside. That's an important number for our hospital colleagues. That's the number of people who are in hospital but don't need to be there. And that's how we're sort of measured. It used to be delayed transfers of care with the old terminology, but that's the sort of the current way of measuring it. As you can see there, the target for Plymouth was 9 and we were hovering just above 10%. That number changes every single day. And where we are today, we're under that. We're actually at 5% today, but it does swing around quite considerably. So in the sort of period after Christmas, we saw it go over 10. So it's quite a volatile number, but overall, we're not far away from where we would want to be for that. So that's good news for people, because they're not spending longer in hospital, potentially deconditioning in a bed when they could be back home, which links into the information on the other side, and particularly the bottom left corner, where the narrative's not quite right. So the percentages that you can see there are the number of people who are complex, so they can't go straight home without any support. They need a form of support after hospital. Those are the numbers who go straight to their own home from hospital. Now, when we started doing this work, only about 23–24% of people were actually going straight home. Most people were going via a community hospital or a care home before they went home. So we've had a concerted effort to drive that number up to 75%. So the increasing percentages is actually a positive story. It's not indicative of more complexity particularly. It's actually indicative of us supporting people with complex needs to go back home, which is generally the right outcome, if that helps. So we're not at 75%, but we are significantly further ahead than we were when we started.
That's the end of the slides. Thank you.
Lovely, thank you. Just a quick one. Obviously, we've had an influx of patients into the hospital because obviously there's flu that was going around. Has that had an impact on people that were already in hospital having to be discharged from hospital earlier than they should have been?
Yeah, I think that's probably more a question for the hospital rather than us. Yeah, I wouldn't want to sort of answer on behalf of the hospital. Inevitably, when there are pressures, we work together to try and ensure people who haven't got any need to be in hospital are exited quickly. So our focus would be, as it is every day, on making sure we can expedite those discharges into the capacity that we've got. And we do see a higher number in January, but that's a slightly different answer to the question you're asking. If that makes sense.
Andy.
Thank you. First and foremost, on behalf of the opposition, congratulations on an excellent result. A couple of questions. Firstly, the OT. What I'll do is I'll just ask one question. I know my colleague there, Councillor Penrose, wants a question, so I'll just ask the first one and maybe come in later on. The OT waiting lists, they're great. They've dropped, 742 to 652, which is quite a significant drop. I understand the approach of waiting well, but I don't understand the wording. Operational expectations have been implemented. What are implementation of operational expectations, and what benefits do they achieve, please?
Yeah, so what that covers is expectations on the number of, I'll say pieces of work, if you like, assessment contacts that the service is expected to deliver. So trying to introduce more common standards so that we can make better predictions about activity. So that's what that covers. It's the expectation that we have as to what we ought to be delivering with the resource that we've got. If that makes sense. It's not that we haven't had those historically, but we've reviewed those and had more of a focus on it. Does that make sense? So
Sorry.
By way of supplementary, just to tease a bit more out of that. So in other words, you had like a convention, but now you've established this in a practice or in a document. Is that what you're saying?
So I guess it's probably more about ensuring that the staff that we've got are as productive as they can be, that we've stripped out anything that they are doing that's not really focused on driving the waiting list down, and that they can be really focused on getting out to assess people in a timely way. So removing other things that perhaps they might have been doing alongside their work, but really trying to drill down so that the assessment work is an absolute priority. Not to say it wasn't before, but I think this is just in terms of our delivery and our assurance process in terms of the productivity of the staff.
Keith.
Thank you, Chair. Just going back to the New Care Act assessments and the waiting lists, it's impressive to see the average number of days to complete an assessment steadily coming down. And noting that trajectory, when do you envisage hitting the target of 100? And I'm just going to add in a very quick one. And if you were to use your crystal balls, once you hit that target of 100, where do you think that target would be set? What at next? Thank you.
I'm going to ask Jill to answer that.
So obviously the work's been ongoing looking at the longest waiters. So at the moment we're down to about 11% being over the 200-day mark. So obviously that brings you into the next target of having the assessment completed within 101 days. So the average days will continue to come down based on the fact that we've got less long waiters, because obviously it's an average. We will be moving towards more around how many character assessments can be completed in an overall 6 weeks. And over the last few months, we are at 41%. That's not where we'd like to be. We would like to see that much higher, but at the moment, you've got 108 people that sit over 101 days. So actually, if we've done that work over the last 5 months, in the next next 5 months, you'd start to see that come down again. And we're hoping to continue that focus of longest waiter, highest priority, but obviously keeping in and check the risk of people as well. So obviously if someone's coming in much more urgent but they've only been in for a few days, we want to ensure that they are supported more quickly. So it is a balancing act, but we will continue to focus on those longest waits. So we will hopefully continue to see it come down, but it will slightly slow based on the fact that we are trying to prioritise a new potential approach, which might look at some alternatives. So we'll continue to monitor it.
Angela.
Thank you, Chair. Yes, it's just a quickie, really. Going back to our budget scrutiny, where you gave really full answers, and I remember asking you about prevention, which was a theme in many of our sessions. And you really did give a very convincing report of many of the things that are happening. And you see in your theme 1, where you look at section 2, I mean, it does look very encouraging. But then, you know, this graph, this green line in theme 2, I know that's not the only measure of what's happening, but if you looking at that and then listening to the budget report about month 8 and the pressures, my question is really a sort of straightforward one. I mean, are you under your pressure yourself, you know, to put there's so much going into dealing with things as they happen, that our work on prevention, which is so necessary and so well conceived, is there a danger that we're not spending enough on that, that we're squeezing those budget lines in order to just deal with what's coming down the track? Just wonder how you feel.
I think it's a really good question, and there is always a danger that you're dealing and putting out today's fire and not with an eye on tomorrow's. I think it would be really misguided of all of us not to have some protected time, protected resource to focus on prevention, and that's what we've done. So we've put aside particular slots, particular time frames, particular hours of staff time to focus on some of that preventative work, so that they're not distracted by some of the other fires that are currently burning bright. And I think it's very easy. It would be easy to put everything into sorting the current issues out, but we would be wrong to do that. So we will hold fast and make sure that we continue to focus on prevention as well.
I think it is a really, really good question, actually. And for demand-led services, it is one of the challenges that you have. How do you do that work for the future whilst making sure people are okay for today? I think one of the things I would say is, if you remember the journey we've been on in terms of where waiting lists and all of those things were, one of the reasons that there was focus on that was because when they are at those numbers, for whatever reason, they become all-consuming to manage and to look after. So the work that's really improved those now creates that opportunity that I think Julie has just described, about having some of that capacity, because when you were sat on the numbers that we were, it becomes almost an industry and focus of itself. So bringing them back down to levels where teams and others are more confident, which is why that work was such an important step, if you like, to us being able to spend more time and protect some time around those really key areas for us now. So.
Lauren?
Thank you, Chair. I do have 2 questions, so happy for you to cycle back to me once others have had. Oh, thank you. So thank you. I do want to also kind of echo comments from colleagues about the really good work that's been done to kind of bring down assessment times. I did want to pick up a little bit on the number of Care Act assessments completed after that kind of dizzying heights of almost 250 between a month between kind of May and July last year. We are kind of slipping down a little bit. Obviously, kind of Christmas pressures, annual leave for staff, I can appreciate why December's number was a little bit lower, but I am worried there is like a little bit of a trend downwards. So I'm just wondering what resilience you're building into the systems to kind of get those numbers kind of back up to that kind of consistent 180 plus assessments completed a month.
Yeah, so some of the work we're doing is to increase the number of assessments completed, but then we want them to be the proportionate targeted review work, which will enhance outcomes for people, ensure we're not delivering more care than they really need, as well as be favourable with the budget. So I think there's a real correlation between some of the work we're doing with the financially and improving outcomes, as I said, as well as the Care Act assessments. So and seasonal pressures. You know, I know we talk about winter whenever we seem to be out of winter, but it has been particularly tricky and challenging winter in terms of weather and conditions and other incidents in the city. So I think that, coupled with annual leave, sickness, absence, and vacancies with staff, I think that's probably an area. Do you want to?
But only another thought that when you're focusing on backlog work and older work, then there's a higher percentage of, if you like, less complex assessments because people's circumstances have changed. By virtue of being on a waiting list for a long time, they probably had lower level risk anyway. So I think we need to see where this levels out, because there's probably some slight inflation in those earlier months because we were getting through more simple assessments quickly amongst the complex ones. As we refine that down to the group that, if you like, really need it, that will also lower a little bit as well. So I think we've got to see where it levels out at.
Thank you. And then my second question, I want to pick up on something you said, Julia, about bringing direct payments in-house. So I work as a personal assistant, not within Plymouth City Council, for another authority. And I know kind of last summer there was big issues with prepaid financial services, with payments not getting to carers. I wondered if you could give a little bit of an update on, are those issues resolved? Have there been kind of any recurring instances? And what themes might be coming up there?
So I'm pleased to say the issues have been resolved, and the bit that I was referring to in terms of bringing in-house is some of the payroll function, because we recognise that might be an area we could make some financial savings, and we could make some improvements for people. So that's the kind of bringing in-house. Direct payments are working well for people. We're putting more through, in a more timely way. And we continue to review the level of direct payments people are receiving and whether it is appropriate to their need or not. So direct payments is a good news story, and there's no other issues with our current provider. So good, it's good news.
Alison.
Thank you, Chair. Lots of good news stories. You've answered some of my questions in your report, and one of them was about direct payments, so sort of good news there. But my question is about the reablement service. The 6-week cut-off I'm reading about, is that rigid, or is there scope for that to be extended for the purpose of kind of maybe preventing the need for a social care package? Just kind of wondering whether, you know, there is just a little bit of give there.
Yes, it's an average 6 weeks. So we would anticipate some people might need less, some people might need a little bit more. I think it's about trying to help focus on outcomes and goals so that people don't end up having reablement ongoing and then others haven't got ability to have any because we haven't got any capacity left. So it's more about targeting goals and targeting outcomes so that people can achieve and then move on and live independently.
Just comment, yeah, thanks. I understand that sometimes it needs a bit less, and yeah, I get that, how it works.
Karen?
Thank you, Chair. I just wanted to ask about the no criteria to reside, and I can see there's been a lot of improvement, but we're still at the 10%. I just wondered if the challenges were in nursing care or whether in home care, and what we could do to improve on that.
Yeah, so as I said previously, that the number changes quite a lot every day. Today we're actually at 5%, so that's a very low number, so well below the 9%, but the average is the average. Typically, the challenges are more about people accessing care homes quickly. It's not about necessarily the availability. There will be some specific complex needs that require a particular resource, but that's why you never get 100, you never get down to zero. There's always going to be that. So it's more about the work we do with providers to make sure people can exit in a timely way. But we have really good visibility of all of the delays and issues through daily calls that we have with system partners, including colleagues in the council and the hospital. But there's, by virtue of that discharge pathway, it takes a little bit longer to arrange that discharge than if somebody was going home, because there's an assessment the care home has to do to make sure it can meet the needs, etc. And that takes a little bit longer. All the while, that creates that longer delay. Whereas the more we can get people home straight away, appropriately, that's really, really quick. And we typically do that in less than a day, so or just over a day. So that's how the two sort of relates. The speed we can support somebody to leave, really, more so than a gap, if you like.
Right. Thank you, thanks.
Just a quick one from me. I'm just looking at the percentage of reviews with increased costs. Can you just tell me why in August it shot up to 34%, and then obviously we've gone steady now at 21%, so it's 18, and then 21%. Why would it have gone up so much in August?
Hard to tell without really diving into the data, but I would anticipate that some of the backlog work that we did earlier in the summer was then came through and was counted within those numbers in August. I would suspect that was probably what's caused that jump up, but we can certainly look into it in a bit more detail if that would be helpful.
Yeah, that would be. Thank you very much. Thank you. Alison?
Really quick one, it would be really useful to have the data for reviews that result in a decrease or a removal of a care package.
Yeah, that's
so we
something.
can see the whole picture. That'd be really good.
Yeah, absolutely, because I think it gives it's a more rounded picture than just what's increased. Yeah,
Brilliant. Thank you.
Andy?
Thank you. I read about care home framework and I noticed it's featured in the report. And it's impressive it's gone live and there's been buy-in, as I see, from 38 care homes. This is not a challenge, it's just to understand the figures in relation to what's been quoted in the report. So it's 38 care homes out of what sort of number? The question is, in anticipation, will others join the innovation steering group? And if they do, what is the advantages of joining that steering group, please?
We absolutely would hope that others would join. I'm just going to pass to Louise. Hopefully she can answer.
Yeah, thank you. Our innovation lot is still out to tender, and we work with those care homes to encourage them to be part of that, so that we can look to develop and shape the market based on the need that we're seeing. So where we might need more complex care and support, to actually work with those providers to encourage them down those routes. We were really pleased with the response to the care home tender. As we said, that went live on the 1st of January, and what that will also do is help us to contain some costs, because care homes are signed up to supplying that care at the rates that we publish.
Has anybody else got any more questions? No. Thank you all very, very much. Do appreciate your report, and obviously it is getting better. You can see figures going down, going up, whatever. So well done to you all. Item 7, adult social care CQC outcome update. We've got Gary from Strategic Director for Adults Health and Communities, Julia Brown, Service Director for HNSASC, and Louise Ford, Service Director for Integrated Commissioning. And I think all three of you are going to present between yourselves, aren't you?
Thanks, Councillor Murphy. It's been a while on the agenda, hasn't it, that we said we would come back to you once we had our CQC outcome. You'll see from the picture, which sadly includes me, how pleased we are really, and we really, really are pleased that following our inspection, which happened back in June, that we've got an outcome of good. And I think what we wanted to do today was just come and share some of that detail with you about that. That will help you then understand perhaps areas for the future that you might want us to come back and report on. But we should just take a moment, really, shouldn't we, just to acknowledge that good outcome, which really does reflect all the hard work and commitment, not only of the teams inside our directorate, we've got our partners, Live Well, we've got Ian here today, but also the effort from people right across the council, in our wider partners and our volunteering and community networks, because everybody really does play a part in this, and it is a whole team effort. So it is absolutely great that we've got to that point. And I thought before I hand over where people will share more detail, you could go to the next slide if you'd like to get rid of the photo for me. That would be good. Thank you. But I'll take you back to January last year, which was when we actually got our letter from CQC starting our assessment process. And at that point, we gave them over 300 documents. We also gave them 50 anonymised cases for them to start their review. So that process started back then. They then arrived and did what we call an on-site part of our inspection, which was in June. And they were here for 3.5 days. They did about 45 formal interviews, both with staff, partners, and those that receive services from us. And it involved about 180 people. So these really are big exercises. And then it took a while for our report to come back in. And what you'll see on this slide is really the headline, and then people will dig a little bit more into it and take you through that in a little bit more detail. That the report is now available on the CQC website for everyone, and we can share that out with partners. And Julia and Louise will take you through some of those areas. But we're proud of our whole outcome. I think the thing I've really drawn people's attention to for us because was around our achievements of outstanding in the area of equity and experience and outcomes for people. We are one of, when I last looked, I think 2 authorities, but it does change, they've released new reports, in the country that have managed to get an outstanding in this domain. And it really does recognise how Plymouth actively goes and seeks out and listens to information from people about those who are most likely to experience inequity in our services. So I think that's a real testament to Plymouth. It's also a real testament to how we don't do this alone, because a lot of that work is undertaken with colleagues in other directorates and other partners in terms of how we go about all of that. So I think that's just a really good example of how teamwork really does come together. I saw you had I don't know how you were doing questions. I saw, Ray, you had a hand up. What I was going to do, if I could, is just hand over, I think to Julia first and then to Louise, just to run through our outcomes by theme in a bit more detail.
Yeah, I think if we could just listen to everybody first and then we can ask questions on the report afterward, if that's all right. Thank you.
Thank you, Chair, and thank you, Gary. So if we're going on to the next slide, please. Within theme 1, assessing people's needs, we scored 50% in this area. So some real strengths around people's wishes and views being considered during the assessment process, as well as 90% of people calling in, the situation being resolved for them at the first contact. We've also had some really strong and good examples of joint working with some positive feedback around our carer assessments. However, we do recognise there's more to do in this space. Our principal social worker is leading some strength-based practice training for frontline staff, and our communication with people and carers to improve their experience is another area that we will be focusing on. Next slide, please. Secondly, supporting people to live healthier lives. We scored a 63% in this area. A really strong preventative focus here in Plymouth with effective reablement services, which we've referenced earlier. And as Gary said, we've got a really strong partnership working between multi-organisations within the council, but also within our voluntary sector as well. So some real strengths. Improvement areas, the occupational therapy offer we've already spoken about, as well as some of our outcomes for people receiving short-term support. However, I would say the report obviously was done some time ago, so we have made some improvements in some of these areas. We haven't been sort of sitting waiting to make improvements. Next slide, please. So Gary stole my thunder with this being our 88%, and really impressive that this is how we scored in this area around equity in experience and outcomes. Some good embedded co-production across various programmes of work, and some really strong engagement with our seldom heard groups, which I think is something to be really proud of. However, we don't want to stop there. We want to do some more work around our cultural competency, making sure that we're capturing our data accurately so that we can really tailor our services to the needs of the population.
Thank you. So looking at theme 2, care, provision, integration and continuity. So we scored 57% for this theme. Some really good recognition of the work around joint strategic needs assessment for Plymouth and how we use that to drive and shape our commissioning priorities, but also how our overarching Plymouth plan provides some really strong strategic direction, not just for the council but for the wider partnership. Great support from the voluntary community sector and how closely we work with our providers, and that's commission providers, not just our partners across the wider system. Good examples of how we give people choice around their care experiences, and how we use that intelligence and that insight to feed back into the services that we deliver, and really positive around our market shaping and the co-production toolkit that we've produced for commissioning. Although, we do know that we have some improvement areas, so we know that we need to do some further work around younger adults, working with colleagues in children's services around their Together for Families programme, Families First, and also doing a lot of work at the moment around dementia and starting to shape a commissioning dementia offer for Plymouth, looking at how we might use tech to support people to stay in their homes for longer, because we know that's the best place for people. We've recently published our carers strategy. I won't steal the thunder on that one, in Julia's words, because we have that on the agenda later this afternoon. We've talked a little bit about the care home framework and the extra care framework, and that was really well recognised, but we know we have work to do with the market, especially around developing the domiciliary care offer. Next slide, please. Thank you. So again, it hasn't moved on. It's me looking at mine. It hasn't moved. Sorry. So theme 2. So we scored really well in this area, 82%. Really good strategic working across the partnership, especially the Plymouth Local Care Partnership, and also how we integrate and work across health and social care. Really positive feedback around the wellbeing hubs, community groups, local outcomes, and we'll use that to feed into the work of integrated neighbourhood teams, the neighbourhood health implementation programmes, and really good commissioning with our voluntary community sector partners. We know we need to do more to strengthen how we engage and feed back further, so that will be an area of focus for us moving forwards. Thank you. Next slide.
So bringing us on to our sort of safe systems, pathways, transitions in theme 3, we've got a really strong home first discharge model, 70% people returning home, which is really positive. Again, we always want to do more, but I think that is a really good news story. We've got good crisis support responses, particularly in terms of our mental health teams. And we've had, as you referenced, really had improvements in our waiting list oversight and the work that we're doing there. Also, in our learning disability pathways, our multidisciplinary working has been really positive. We have, in terms of improvements, we have had mixed experiences for those young people transitioning into adult services. We have a joint plan with our children's colleagues underway, and we've have a joint select committee in the next couple of months to really explore that area a little bit further and what we can do together. The next slide references our safeguarding work. People generally feeling safe across the city, which I think is positive, and we have clear and timely systems for reporting and reviewing our safeguarding work. We have an advice line which was really valued by our customers and partners in our care market, and a very strong multi-agency safeguarding partnership here in Plymouth. We also have good training levels for our Mental Capacity Act training for staff, which is above our national average. Our improvement areas remain around our deprivation of liberty safeguards work, both for the deputy of liberty safeguards in care homes and those in the community. the numbers are high, and we have some work in progress to make some improvements in that area already. Documenting how we make safeguarding personal for people, so that is how we help people to make sure that they're getting what they need from the process, and how we're documenting that is another area that we're doing some work on, and we have already started some of these improvement areas.
Thank you. And then moving on to theme 4 around governance, management and sustainability. So what CQC recognised was that stability in the leadership across the directorate with some clear roles and responsibilities, but also really regular oversight through performance reporting and management and assurance, and really how we use that data to drive our decision making, really positive culture around learning and improvement and supporting our staff to develop, and really listening to staff to understand, you know, their perceptions and their thoughts and feelings, and active partnership engagement at a senior leadership level across health, the voluntary community sector, but also more widely across Plymouth City Council. So in terms of improvement areas, yes, we know that audit processes would benefit from improvement, so we've been working with colleagues to standardise our audit processes, improve that engagement across the teams and the directorate. And there is some workforce capacity challenges in some areas, but again, that's something that we're looking at both as PCC, but more widely through regional approaches. Next slide, please. Thank you. And then finally, learning, improvement and innovation scored really well in this theme, with strong workforce development and a lot of focus on the assessed and supported year in employment, the AYSE programme for new social workers, developing those career pathways, really focusing on how we use co-production in the service design and the tenders that we develop for going out to market, and that really positive culture of continuous improvement. And just in terms of the improvement areas, I think Julia's touched on DOLS, but that's something that we still need to do some work on to build the skills that we need across the service. Thank you.
It's nice to sometimes have the last word, isn't it? Which I do on this one. But I think we really do need to take a moment, don't we? Firstly, to acknowledge well done to everybody and give out our thanks to people. But we have to also recognise that that's not everybody's experience of our services, and that report also talks about areas that we need to focus on. So as much as we do want to shout out and say thank you, I think we also need that acknowledgement that that won't be everyone's experience of us, and that what we need to do now is use that report and all the insight we have around our services to keep moving forward. And I'm sure that will be part of the conversations for the future in terms of how we work along with Scrutiny and other things to help drive that journey. So yeah, so thank you.
Thank you, Gary, and can I thank you all, because I mean, this is an amazing report, and it's read. I mean, that is just amazing, and I know myself and Mary, we can remember this day quite well because we also got interviewed. And I think it was like 45 minutes. And it was really, really intense. So for everybody that went that got interviewed, and I can assure you, it wasn't easy. The questions that they kept firing at us were really, really, really hard at times. But obviously, we all must have done well. But what I need to know is, Mary, is why we're not in that photo.
Well, I should have been, but unfortunately I got hit by the dreaded bug and I was in bed. But we'll get another one done, Pauline, definitely.
Yeah, I mean, I should be in there. I mean, I did get interviewed, Gary.
Yeah, we had to suffer, didn't we?
But well done to everybody. This is an amazing achievement, because I've just actually asked Gary, and the last one was about 14, 15 years ago. So to come out good is just absolutely amazing. So well done to everybody that's been involved in this. Keith.
Thank you, Chair. I mean, even as a relative layman, I can see that this is a good outcome, and I'd like to congratulate everybody on achieving it. But referring back to being a layman, some of the language I'm finding a little bit difficult, and I wondered if you might just give an outline of what a deprivation of liberty safeguard is and what its relevance is within this report. Would that be
possible.
Yeah, so I'm happy to talk to it unless you want to.
I'm quite happy
Do it, yeah.
It'd be a good test of
it would be a good
my
test.
social work. I can claim this as CPD when I re-register at the end of the year. So a deprivation of liberty safeguard is for people who lack mental capacity to make decisions about their care and treatment and where they live. The safeguard is to ensure that those individuals are only subject to restrictions that are in their best interest and are proportionate to the risks that they pose themselves. So it's a legal framework, requires people with particular qualifications to carry out assessments with doctors' advice to effectively ratify the care arrangements that they're subject to. It came in as a piece of legislation quite a long time ago to close a gap in our law. Prior to that, we relied on case law, if you like, to sort of common law, sorry, not case law, to justify the actions on behalf of that person. That was not sufficient to tie in with the European Court, etc. So that's where the legislation came from. I've remembered a lot more than I thought I would. Does that help? So that's what it is.
No, that helps a great deal, and thank you. I'm sorry for putting you through having to remember all of that on the spot, but thank you.
Is there any more questions? Ray, and then Alison.
Can I ask about the CQC visit? Was it done in the council house or did they go out to visit partners?
So they came down for 3.5 days. Their base was at our offices at Crown Hill Court that we share with Livewell. What they did as part of that 3.5 days, so they did go down to some other sites. They went down to the Mount Gold site where some of the social work teams are, and they carried out some work there. They also went out on their last day. They went to one of our wellbeing hubs, so they then met voluntary sector, and they got involved in some of the things that were going on there. So they were mostly based at Crown Hill Court when they came, but they did do some other extended visits. But to make that efficient, lots of people come to them, although we did encourage them and they did take the offer up to get out into some of those other places as well.
Thank you.
Alison?
Deprivation of liberty. I was wondering whether it would be useful to have that data on our agenda to sort of bring that in each meeting, just to see how those waiting lists are going. I suppose my concern is the high waiting list for people in residential care waiting for a DOL assessment, and I kind of find that quite worrying. So if it's, I mean, I'd quite like to see it actually, not necessarily over a long period, but just while the team's working on it, really, just to make sure that things are just for our reassurance. But otherwise, well done for that. I mean, it's brilliant. I mean, it's just such a massive remit, isn't it? And social care and the achievements are immense. But yeah, so that's a request really from me.
Sure, sure. I mean, happy to bring some of the data along, and it's early days in us looking at it, and because it is quite a large list. I suppose to reassure people, we're not worried that those people are not safe. Those people are safe. Good decisions have been made. There is the legal framework which we need to follow to complete that assessment, which Ian spoke about. So we're not worried that we've got a lot of people in the city unsafely being cared for in residential or nursing care at all. Quite the opposite, really. This is just making sure that we're compliant with the law. But yes, we can certainly try and build that data reporting in to our next report.
Like Gary just said, we can have a little focus session on it, and yeah, that'll be fine. Right. Andy.
Thank you. I'll be quick, Chair. Certainly there's some degree of linkage between the theme 1, where it's a great report, and once again I reiterate my thanks for that wonderful outcome. Theme 1 does show half points on it. The linkage back to item number 5, I know budget scrutiny's gone, and I don't want to dwell on that. Just want to make sure that we have sufficient financial allocation to improving theme 1, because that seems to be the only Achilles heel in the system. Thank you.
Yeah, so I think important that it does link to budgets. And what I would say is this report was done based on the data back in the summer. So we've obviously moved on 6 months, 4 months, 5 months since then. So things have progressed. I think the assessment of need and the budget, it's important that we're assessing need proportionately. We're not spending more money than we need to spend, and we're enabling people to be as independent as they can and not reliant on services and waiting for people to come in and provide care for them. Are there other opportunities, technology, other things that we've mentioned earlier this week, last week at budget scrutiny? So the things do link, but I think things have moved on quite significantly in terms of our assessment of need.
Any more questions? Okay, no, Alison, you ask. That's fine.
Thank you. So under theme 2, so I'm looking at emergency respite care. It seems that there's a need to kind of try to improve that, and I'm thinking if you've an unpaid carer maybe is kind of running out of steam on their knees, kind of how soon they can expect to receive that help, and kind of where are we going with that really at the moment? Thank you.
So I think I'll work with our with assessment for our carers, making sure carers are represented and their needs are well met. That's work that we do with Improving Lives Plymouth in partnership with them. And if respite care is the option that's the best for that person, then absolutely we would look at that. That's not always the right. Some people might think that respite into a bedded setting in a residential home might be the only option that perhaps they've heard of. So it's really important that we explore all the different respite options for that unpaid carer. And that could be a whole host of different things. So I think it's important just to kind of reference that when we're looking at how we're supporting carers.
Can I also, sorry, just come in and say that we do have the carer strategy on the agenda, so we could pick that up in terms of the implementation plan and some of the work that's going on in that work stream.
Just want to know that that a residential placement is available if needed in those circumstances where, you know, maybe a family or whatever are really struggling. Is that kind of immediately accessible? I mean, if not the day, but kind of, you know, imminent if, you know, if it's really needed. I know it's
simple
not
answer, yes, it is.
Yeah, okay.
Any more questions? Nope. Thank you all very much. And once again, you all should be really, really proud of what you've achieved on this report. And hopefully, maybe the next one will be in 14 and 15 years' time. Maybe you won't have to go through that again so soon. But yeah, I know it was really, really intense because I know we were very, you know. But anyway, well done. I've been asked to change the order of business, and winter pressures update would like to go before Plymouth citywide, the unpaid carer strategy. So I'm quite happy for that to happen. Can we have a proposer and a seconder that we do that, please? Right, a seconder? Yeah, Maria. Okay, is that right? Ella, you got that? Thank you. Right, so we're going to go to item 9 now, which is winter pressures update, and we've got Amanda, Nash, and Michael Whitcomb, and and Gary and Louise.
Thank you, Chair. If it's all right, I'll start off from my perspective. Apologies, I'm not with you in the room and not physically joining you today. Just from the winter plan summary from UHP is a bit of an update as to where we are and our capacity summary as part of the slide plan. Unfortunately, 50% achievement of the one plan objectives of reducing our no criteria to reside in our admission avoidance schemes has been not as fruitful as we anticipated, and we've had an escalation open. And as you can see from the actuals, we've had a minus 54 bed state from the beginning of October earlier into the journey of as we headed into winter, and sustained at the moment around about minus 40 as we go into December and January. Just to give you an idea of that no criteria impact and the beds lost, but our anticipation would have only been a minus 8 bed lost with escalation and mitigation that we've put in place. So it has, although been a challenge to deliver winter, we have improved our ability to respond. And just moving to the second slide, in comparison to our ambulance handover performance summary, we lost around 2,000 hours in December to ambulance deployment, which comparatively for December last year, we lost 6,344. So it's a huge improvement. Still not where we would like to be, because we'd like to not be holding any ambulances at all. And we do not admonish ourselves from that responsibility, but just to recognise the improvement and the effect that both the acute and community teams working together has provided. Apologies, I've probably gone straight into talking and the pack wasn't shared. I apologise for that. Thank you, Elliot. For our 4-hour standard for UBC access delivery, unfortunately we've seen a deterioration in that performance greater than what we anticipated against our trajectory and plan. So there are some recovery actions in place to improve that, so we move our patients through the system in a more expeditious fashion. From a vaccination update on the next slide, the second one, we have improved the vaccination uptake at UHP this year, so there has been a greater uptake against that. And also for Devon overall, we have achieved the 5% improvement, which was expected from us, so that's a real achievement, but still enough for us to benchmark ourselves ready for the next vaccination uptake. And there's some particular areas of target that we would like to learn from this year that we are going to push ourselves for the next winter months coming through. So I won't go obviously into the granularity of all of the detail and numbers, but it's there for your information. And I'll hand over to Amanda, who's in the room from a comms perspective, just to give you an update in relation to the response on winter and the communications.
Thanks, Michael. A few of the members of the committee joined us to see our new urgent treatment centre, which I know the committee particularly asked us to give an update around our new urgent treatment centre. So councillors Penrose, Noble and Morton came to see the urgent treatment centre in November, and you asked us to talk about the difference that has made in terms of winter. So we did a huge Think UTC campaign to make sure that the people of Plymouth knew about the urgent treatment centre, because it was a major part of our plan for this winter. And as you can see, there's a graph there on the right hand side, and there's a thin dotted line that runs up the middle, and that shows when we started our community-wide campaign, which has featured across social media. You might have seen some of the banners in Transit Way, etc., across media, Heart Radio. We've done Spotify advertising, etc. And you can see that since we started that campaign on the dotted line, with the exception of the Christmas week, we have seen a growing demand and growing number of attendances at UTC. And in fact, the 11th of January, I think, saw our highest ever numbers in terms of attendance at UTC. So we are definitely making sure that people in Plymouth and the surrounding area know about the UTC. They know what it's for. So our campaign has been about when to use an urgent treatment centre as opposed to an emergency department, because obviously the aim of the campaign is to drive as much as what we would call ambulatory care as it is safe to do so there, so that people with minor injuries and illnesses go there first. And that's had an impact in terms of we have seen more people going there, and we've also seen the number of redirects from our emergency department falling because people are going there first. Sometimes we do have to redirect people from the UTC to the emergency department, but we'd much rather them go there first if possible and if it's safe to do so, and then we can redirect them. So just to reassure the committee, beyond those councillors who came to see the UTC, that it is definitely well publicised, well attended, well used, and it's had an impact this winter, hasn't it, Michael, in terms of its presence?
Angela.
Thank you, Chair. Could I just add that there was another method of communicating this, because when we had our visit, we were so impressed. I never shut up about it.
Oh,
so everybody I met, I said, you know, if you burn yourself, trip over, bang your head, up you go to UTC. It was really worthwhile. Thanks so much.
Thank you, Councillor Penrose.
Is there any questions? Will?
There's obviously the figures here show an increase in the uptake of the flu vaccine. What is it too early to see? Because obviously the last month has been the very busiest. That bit after Christmas is always the busiest in the hospital. I can say that anecdotally, but I think your figures, if we look back in a few months, will definitely show that. But has that, some of these things that can be done in advance of the expected, you know, to divert people, has that as a campaign that's been quite prominent? There's lots of interesting posters in the hospital with various slogans on them to encourage staff to take the vaccine, but obviously, you know, visitors and the patients see those as well. So has that had an impact?
I'll bring Michael in a second. In terms of our staff vaccination campaign, it's been very successful. As Michael said, we've increased by our target 5% and probably a bit more. So that's been great. I think we saw a real uptake just before Christmas when we knew that there was going to be a rise in flu cases. So our campaign starts in early October and it had been quite steadily growing, and then I think staff recognised that there might be more flu cases in the hospital, and we had a bit of a flurry of activity then. But yeah, overall we're really pleased with our flu campaign this year, aren't we, Michael? And I think peer vaccinators, so staff who work in the hospital as well as staff vaccinating, going around and vaccinating colleagues, has been particularly successful. Would you add to that, Michael?
Yes, absolutely. So there has been the impact of the peer vaccinators, and I think that's been the driving force. The benefit of that, particularly for, although we've still got a way to go, so I don't want to jinx ourselves too much, but from an infection prevention and control sense, the flu and RSV demand, particularly across the acute bed base, has seen less of an impact. It's more controlled, it's been staggered. Our response has been different, and our anticipated proactive response has probably seen less of an outbreak and spread. So there is some connecting of the dots to do, quite rightly, in a full analysis of the winter, particularly informing earlier for next winter as well. So in answer, yes, anecdotally at the moment, but giving you numbers, I'd hope to do that at some point when we come back to you.
Thank you, Chair. So just going back to vaccines again, on page 97 where it says the Devon RSV eligible totals, does that mean that only 45% of the general population in Devon have taken the jab, the injection, you know, the vaccination? What does it mean?
Do you want to pick that one up, Michael?
So for the 47%, so page 90, sorry, I only have it as page 5 in my pack. Are you talking about the graph for the Devon Winter Vaccinations Weekly Summary?
Yeah, that on the bottom of that page is like a running total. Uptake of 45.92%. Is that community or is that hospital? And is it led by GPs or is it led by the hospital?
So it's uptake by trust. and that's 45.7%. So TSD and RDUH and DPT all captured. So that's the uptake per staff within the trust. From a population sense, so I don't have the overall percentage figures, bar the Devon RSV eligible running totals in the right hand side. So some of this data I'm reporting on their behalf. So I wouldn't be able to give you the accuracy of those figures of what it is from a population sense and community, only to talk to really what the trust is reporting.
Anybody else got any more questions? Will?
In the last week, the BBC did a focus on the NHS. How important is it that some of the other aspects we hear a lot about the in the one plan, the admission avoidance, patient flow, timely discharge, but how important I thought some of the coverage last week showed some of the other things that are going on outside of the hospital, like I think it featured like an X-ray car and there was some stuff at Cottage. The bit I watched was Cornwall based, but I thought we have these things here happening. We have our versions of that operating from Derriford. How important do you think that is? Because some of the reporting over the winter is focused on the corridor care or the big queues or what have you, and I think there hasn't always been that kind of what is going on. How important do you think that is to get people to think about using alternatives or making plans for their health rather than not paying attention and then being in those crisis situations?
Yeah, you're absolutely right. I'll talk a little bit about NHS Day and then hand to Michael in terms of admission avoidance. But yes, it was NHS Day run by the BBC last Thursday, and we put together a really important package. And you're absolutely right. We really focused on out of hospital care. So we focused on, and we've got more to do around our community frailty virtual ward, but we showed them the X-ray car, we showed them lung cancer screening as well as the urgent treatment centre. And that's part of our campaign all the time, which is to stress the alternatives to the emergency department so that people can try and use those in a way that's either preventative, like the lung cancer screening and actioning things like that, or to go to places like the urgent treatment centre. They are really important in answer to your question because they help people get care in the right place at the right time, and they also help relieve demand on the emergency department. But yes, you're right. We did also show our X-ray car, and we've had more than 400 patients have benefited from using that car, and the vast majority of those, I think it's over 95%, have avoided being brought to hospital because they've been visited by the X-ray car and therefore cared for in their own home. So a really good success story. Wider on admission avoidance, Michael? Did you want to add anything wider?
Well, no, not particularly. From an operational sphere and clinical, with my clinical background, it's better for the patients in the community to remain within their own homes as much as possible. The national directive for hospital to community is our main focal point and is something that we are striving to improve as we move forward. And we know that patients recover well within their own environments. So they are less likely to be exposed to, particularly during winter, to other forms of infection and other sources, as well as we mix population. So yeah, that's really the only benefit to add. It is our main forward view, strategic view, as we head going into 26 and 27 and as we continue the years. So great question.
Maria?
Have you got any sort of figures about how the community frailty wards had an impact on people not going to A&E? I know like same-day emergency care has had a significant impact throughout the hospital.
Yeah, you're absolutely right about same-day emergency care, and Michael can pick that up. Have you got community frail virtual ward stats there with you, Michael? I can see him looking up at his screen. It might be a little early to report against them, but we could certainly bring that back. Livewell run the community frailty virtual ward, but we've also got an acute virtual ward. They're quite different things, but yeah, we could definitely bring that back if you wanted us to.
So currently at the moment, the latest figures, they had 55 on the caseload of a capacity of 95. So they are striving. There's some really important work that Live Well and ourselves are doing to onboard patients and view them kind of 48 hours before their predicted discharge. So we're really taking more of a proactive response, and we should see those numbers increasing as we move through. So that's kind of a bit of a summary, and apologies, I haven't got any more granular detail for you at the minute.
I just wanted to say that I've had personal experience last year of the virtual ward with Live Well, and they were absolutely fabulous. And I think that's a really great area to expand on to get people out of hospital quicker and prevent admission. Is there a plan to extend further on the virtual ward? Go on, Michael.
Yeah, absolutely. So as part of the single point of access work, part of our increasing the capacity and the onboarding sense and how we can really stretch our ability, particularly as we bring in the new electronic patient record, and as we move the push, as I've already said, from hospital to community. So we're going to be looking at all of the aspects to really optimise that, to give the same sort of experience that you've had, which is absolutely fantastic. So great that you've had a positive experience, and thank you for sharing that.
Louise, oh.
Michael just mentioned the electronic patient record. I think it would be really, really good for them to come here, and I'm not saying go into huge details, but tell us about EPIC and how that is going to affect them and us, because obviously they'll be linking with us at a future date, Chair. And I think it goes live in July, doesn't it, Michael? It does. So somewhere before then would be very useful.
Louise, I understand that you're giving us an update.
Yes, I am. Elliot, do we have the slides, please? Thank you. So this is a combined update from my colleagues at the ICB and the commissioning service. So at the last Overview Scrutiny Committee meeting, you had an update on our winter plan, and we outlined what we'll be doing to ensure that we were reducing delays, supporting people and maintaining that patient flow across the system. So this is just a light touch point to say that we continue to work together in partnership with our colleagues at University Hospitals Plymouth, Live Well, NHS Devon, to support any daily escalation calls that are needed, any conversations around complex discharge for patients, just to ensure that people are getting the right care in the right place at the right time. We work collaboratively together as Plymouth City Council Commissioning Service and our colleagues at the ICB around market capacity, ensuring that we have what we need across the provider market to support any surge that might be needed. We have been, touch wood, very lucky so far in terms of our capacity and the need this winter. We've not seen any challenges from our care home or our domiciliary care providers, so we're managing that flow across the system. Next slide, please. We continually manage and monitor that demand and capacity to make sure that we do have what we need to support people, and any pressure points that are emerging, and we'll implement any mitigations as necessary, and we do that collaboratively together. And there's also a much wider Devon-wide oversight arrangement in place through our colleagues at NHS Devon. So just a couple of the challenges that just to flow through. So norovirus flu challenges, they have been, they're still there. They've caused challenges across the system, but we're not seeing anything in care homes which is causing us any cause for concern. So all of the work that we've done around the vaccination, but also the infection control, so using those provider forums that we have to really push around hygiene and maintaining the right levels of PPE across our settings to avoid any transmission of bugs. And I think, already picked up on in terms of the communications that have happened on the final slide around vaccinations, pharmacy first, thinking about, going into settings if you're unwell. So I know we've touched on that, but we will provide a much more detailed update on what's happened across the winter to the next scrutiny meeting. We'll get through winter first. Thank you.
Andy?
Thank you for that report. I see that the norovirus has got astronomical proportions, hasn't it? 47% higher in the first 2 weeks of the year than the same time last year. Now, you mentioned in there that keep away is the advice, and you also mentioned increased cleanliness across the world. Are there any more proactive steps that have been taken? Because, I mean, this is a colossal hike, and I fear gravely for people who are in hospital, but this has been a massive threat to life and well-being. Is there going to be a more concerted effort to try and eradicate this, other than just increasing cleanliness and PPE?
I'm not sure how we're going to eradicate norovirus, but what we would say is we would continue to push those messages around. If you're unwell, please stay away from settings where there are vulnerable people. If you are unwell yourself, continue to to drink fluids, take painkillers as you would need, rest. And within our care homes or our provider market, like I say, we really push hard on the PPE, having the right equipment in place to support people. But if people are not well, then please do stay away.
Any more questions? Thank you all very much. Thank you, Michael. He's gone. Gary, did you want to say anything? No, that's right. Thank you, Michael. Thank you. Thank you, Amanda. Thank you, Louise. Right, now we're going to go to item 8, which is Plymouth Citywide. Oh, have we got people here, by the way? Or are they? Oh. Oh, right, okay. But Elliott's just going to go and get them. I think we're just probably running a couple of minutes early. Okay. Good afternoon, everybody. We're on item 8 now, which is Plymouth Citywide All Age Unpaid Carer Strategy 2025-27. And I'd like to welcome Kate Lattimore, Commissioning Officer, Mark Collins, Strategic Commissioning Manager, and please excuse me if I don't say this right. It's Victor Kitty Korakan. Manager of Caring for Carers, Improving Lives Plymouth. Thank you. Don't know.
Yeah, I'll just introduce. So, thank you, Chair. So this item is going to just give you an update on the Plymouth City All Age Unpaid Carers Strategy, developed in collaboration and partnership with the health and social care system here in Plymouth, really supported by a detailed implementation plan. And that's something that we want to drill down into today with you, just to give you assurance that this is moving, that we're following through with those recommendations to deliver the absolute best for our carers here in Plymouth, because we really value the work that they do. So I'm going to hand over to Mark, Kate and Victor. Thank you.
Thank you and good afternoon.
So as I said, I'm Mark Collins, I'm Strategic Commissioning Manager. The carer services sit within my portfolio. I manage Kate and Victor delivers part of our service. So I wanted to start really just talking about what the unpaid carer strategy is. So if you could move on to the next slide, thank you. Our 2021 census, we identified in there 24,000 carers in the city. So that's quite a large proportion of our population of unpaid carers. And nationally, that turns into about 5.7 million unpaid carers in the system who are providing care for family members. And the school census in 2024 identified 730 young carers with those in school, but we know that number is a lot higher. Through our work with the youth service, so far we've identified 1,300 young carers in the system. So it's quite a broad number of carers that we've got out there working in the city. We also know that about 3 in 5 people in the UK will become carers at some point in their lives. Our GP survey in 2024 identified that 70% of carers will have a long-term physical or mental health issue compared to 59% of non-carers. So there's quite a dramatic difference in outcomes for carers in the city. So we felt that the strategy was vital to ensure these carers are supported to be able to deliver the work they're doing. We also have concerns around our young carers because the impact of their care responsibilities is also impacting on attendance and attainment at school. And the Carers UK last survey reckoned that young carers were losing 23 days a year schooling, which is quite a substantial element. So that's one of the reasons why we wanted an unpaid carer strategy. So we've developed this strategy. There's some key figures there that we put on the front, which are a bit difficult to read, but it does basically highlight some of the examples that I've been giving you. Women more likely to become carers by the age of 46, which is quite young. The strategy is on Plymouth online directory, so it's on pod, it's widely broadcast, and it's a partnership between quite a number of people within the care system. As Louise said, we've got ourselves Improving Lives Plymouth, who are our main delivery partner for the Caring for Carers service, St Luke's Hospice, the hospital, Live Well, and Time for You, which is a partnership between our City Council Youth Service and the Children's Society, thank you, Victor, I was struggling with that one. The Children's Society, who deliver a bespoke young carer support service as well. So, some of the challenges we face for carers. We know that within the adult social care sector, there is a huge workforce recruitment retention problem. There has been for some time. We are working on it, but it does mean that there is an increased burden on our carers because there is a shortage of paid care for some. Insufficient funding, low pay, reliance on informal family and friend carers. We've got an ageing population, people living longer with more complex needs and conditions. Caring will feature in even more people's lives in the future. And I've already mentioned that about reckoning at the moment, it's around 3 in 5 people will become an unpaid carer. And every day, 12,000 people become an unpaid carer in the UK. Quite a daunting picture. So the strategy is vital. So we did a lot of work on developing this strategy. We ran a lot of task and finish groups to look at the information we were getting. We did a lot of research. We looked at a lot of the statutory guidance around what do we need to have. But the most important bit that we've done is actually engaging with the carers themselves, talking to huge numbers of carers and people that are cared for around what they wanted, what support they needed, what wasn't working well for them, and also what was working well, because we have to recognise that we do provide fairly good support for carers. So a lot of effort went into pulling together all this information and into a very clear strategy from which we drew out some key priorities, of which there are 6. At this point, I'm going to hand over to Kate, who's going to talk you through what the 6 priorities are.
Yeah. Mark, so from all of so from all of the work that Mark just mentioned, all of the like the consultation, looking at best practice, looking at NICE guidance, there's loads and lots of information, looking at what other areas come and are doing, and most importantly, talking to carers. We identified the 6 priorities. So number 1, the first priority was around access to support service that work for carers. So carers said to us that the services that they receive, but really importantly, the services that are delivered for the people that they care for. So about how they communicate with each other, not having to keep kind of like, you know, telling their story and over again. So those kind of things like waiting lists, etc., which we know kind of affect everyone, but carers told us that was a real issue to them. Financial support, so carers often have to carers may leave the workforce, so people actually so demographics, people usually kind of start their caring journey at the age between 45 and 65. That's when there's more carers, so that's when people are kind of like at the peak of their, you know, their working life, and sometimes people have to leave their work in order to be able to care for their loved one. Or sometimes people have to care full time, and carers allowance is one of the lowest benefits. So financial information, knowing what's out there, knowing what support, what benefits are available around the workforce, etc. That was another key priority area. The third one was around improved health, safety, and well-being. So carers want to, you know, they often have issues around their own mental well-being. So access to counselling, access to peer support, also access to respite and tailored breaks, so that carers can have, you know, get a bit of a break from their caring activities. So that was really important to them. Early identification and recognition of unpaid carers, so ensuring that people are aware, you know, who are the carers, because often carers don't actually recognise that they are a carer. So research tells us that it takes on the average about a year or so for people to actually recognise their carer. For a carer, it's, you know, there's someone's it's someone's daughter, it's someone's partner, it's someone's sister, brother, it's a friend of theirs, so they don't actually see themselves as a carer. Also, carers often say to us that they're not actually involved in the discussion around the cared for person. So someone can be in hospital, or they could be supported by a social worker, and that social worker doesn't always include the carer in that discussion, that conversation. So that's another thing that carers said to us, that they want to make sure that they're kind of better recognised. Having improved information, advice and communication, so that's another thing that the carers said that they wanted to see improvement, that's really important to them, about knowing where to go for information and knowing that it's up to date. And also the final one was around when the caring role changes, so that covers things like when people's caring, so their caring journey might come to an end, unfortunately, and that could be either that the person they're caring for gets better, or it could be sadly that person, you know, passes away. So and then it's also around transitioning. So this strategy is around, it's all ages, so it covers young carers as well. Although this is kind of like scrutiny for adults, the carer strategy covers all ages, and we have carers within Plymouth, you know, that are caring from the age of 2 or 3. So it's kind of like a very young age, and so when they kind of go through that transition, when they're 17 going on 18, so their the caregiving role will change as well. So that's another area that we focus on as a priority. So we've identified all these different areas and all these different priorities, and so the next stage was to think about, well, what are all the different action plans, what are all the different actions that we can kind of carry out to ensure that we implement the key priorities that were identified that I've just talked to you about. And one of the ways of doing that was representatives from the 6 different organisations that Mark mentioned that were involved in creating the strategy. So we met regularly. We also sit on what's called a Carer Strategic Partnership Board, which is just one of the many partnership boards that exist. But that's a partnership board that meets every quarter, and it has different members. So Mary's a part of that Carer Strategic Partnership Board, and it's just got all the key partners within the city that work with carers, really. So it's from the health and social care, but it's also from education, etc. And then we created an action plan. So the working group has created an action plan with the different actions to ensure the delivery of the plan, and we meet regularly just to sort of fine tune the plan as well and ensure it's being delivered. And then progress is reported back to the Carer Strategic Partnership Board. So the next stage of the presentation, so we've got the 6 priorities. So we're just going to talk a bit about some of the key achievements that we've delivered so far. So I'm just going to talk about the first one, and then Victor's going to talk about a couple as well. So the first priority was around access to support services. So some of the key achievements that you can that you can see on there. So this was around about reducing general assessment waiting times, about better coordination between the different services so that they're aware around carers, so there's not such a long waiting time. So adult social care have created a RAG rating tool. So this is like a waiting well policy, and it's just so for people who are waiting for an adult social care assessment, and we know that there's quite a long waiting list, and that's for the careful person. So this RAG rating tool will look to see that when people are waiting for their assessment, that they're waiting well, that they know they're aware about other services that might be available in the community, and then they'll also look to see whether carers are, if there's a carer involved that's caring for the cared for person, that they'll look at their well-being as well, and if it looks like that they might be at risk or carer breakdown, then there's different measures that will be put in place. So Live Well are doing various other actions as well around about how they involve carers. So carer support plans that Live Well create. They're reviewing, and they're involving carer focus groups. A survey has been issued to all members of the Carer Strategic Partnership Board to look at, to understand about how the different organisations communicate with each other. How can we improve on that communication, and things like looking at phone lines and emails that are available to carers, and with the aim to identify new ideas. Things like the mental health inpatient units are looking at their discharge process and how they can improve, how they can involve carers, and so carers are really kind of part of that. And then things like virtual wards and discharge to assess. So they're all the kind of like the different policies around, which I'm sure that you may well be familiar with. And it's all around how care can be delivered to people at home, which can have lots of benefits, but it's also around ensuring that if someone's going to be cared for at home, and if there's a carer involved, that could potentially put more burden on them. And we're also piloting something called the triangle of care, which I'll go on to talk about, but I'll just hand over to Victor now. So Victor leads on priorities, the next priority area.
Hi. So the second priority is around enhanced financial support for carers. So looking at the different means that carers are able to access financial support across. In terms of what we are currently doing, so we have been very fortunate from our side that we've been able to secure some extra funding to be able to run a program called Carer Money Matters, which is a specific program around income maximisation and fuel poverty, which is currently being funded by Carers Trust. That program concentrates on helping carers through the provision of navigating the difficulty within benefit system and looking at their current fuel providers and seeing if there are better options for them in a system. We have been able to support over 500 carers so far in the last 18 months through this program, and the total value of that support have been over £1 million, meaning that roughly for every person attending the program, we've been able to increase their income by about £10,000. The later parts around the second priority looks at entitlement reviews in terms of what carers may be entitled to, because of course not every carer is completely familiar with the system and what their entitlement may be in terms of benefits, in terms of any other grants that may be available. We have got access to certain grants within our remit, and this extends to some of the other more national grants that we might be able to access as part of that. For example, Carers Trust grants that may help carers to increase their income through their provision. The energy saving advice and cost of living support. So again, we have got our advice project, which is all around benefits and all around cost of living support. We have been able to also draw up on the household support fund that we have administered through our organisation, which has been a great help to carers as well as the general public. And we have just been able to establish some links with the Connect to Work, which is a new scheme all around getting people back into employment. And the Connect to Work scheme has got two specific carer related individuals who are coordinating that work, and we've been able to draw upon their expertise and signpost carers to that programme so they can help them with getting them back into employment. The second priority is mainly all around creating stability for carers within the financial means and being able to navigate through the different support functions that there are. Priority three, wrong priority. Priority three is all about health, safety and well-being of carers. So it looks at the emotional and practical well-being, respite counselling, peer support and digital tools that help and contribute towards carer overall well-being. As part of the priority, some of the key achievements so far have been we've been able to look and establish an enhanced sitting service, which is a regulated care sitting service for carers they can access for the cared for individual. That can range anywhere between 2 to 8 hours per week, and carers can have their own ongoing basis. The volunteer-led sitting service, which is currently being delivered by one of our partners, Elder Tree, who have many years of experience working with volunteers. They are able to match volunteers to the cared for person on a week-to-week basis to provide some respite break for the carers so they can go and enjoy doing an activity on their own. We've piloted a scheme across Devon, where we look at discounted hotel stays and breaks across Devon for carers specifically. So anybody who is registered within our service receives what we call a carer's passport, and the carer's passport is part of the Devon-wide scheme, which allows them then to access hotel breaks, days out, and other activities within the area as available. It also gives them access to certain discounted services across the city. We offer counselling to carers. We have got a specific budget which allows us to sample carers to one of our counselling partners. We use a local counselling firm which offers carers 6 sessions or 1 hour sessions, and they can access this on a sort of year-to-year basis. We currently run 9 separate support groups on a month-to-month basis, and these are sort of drop-in sessions that we run across the city. They are kind of scattered across the city. Some are run from our hub, wellbeing hub, some are run from the community, and this is just a chance for carers to come in and have their peer-to-peer support with other carers across the city, get the information, and be able to just have a bit of a break from the caring role whilst within that environment. And we are currently in the process of launching an online digital solution for carers called Bridget Care, which is a comprehensive carer self-helping tool, which will enable us to have this running alongside our service, and we'll be able to signpost carers to it. And it's all around helping carers to get the right help at the right time, meaning that they'll be able to go into the app, type in certain information into it, and based on the information that they've provided, it will then give them answers regarding their current or present situations. Thank you.
So I'm just going to whip through the Priority 4. So just some of the things that we've done in terms of the delivery of Priority 4. So that was around early identification and recognition of carers. So some of the actions that we've done around that was it's called like it says 3 adult social care teams are part of what's called the Triangle of Care pilot. So the Triangle of Care is basically, it's kind of like a quality standard, a quality tool, and it's called a therapeutic alliance between the actual services, the care for person, the person that's got support needs, and the carer. And it was just done, and it was trialled in mental health services, and it was just in recognition that quite often the carer was actually kept out of the conversation, and that can have all sorts of effects. So when someone's in hospital, for example, and when they're discharged home, if the carer's hadn't had an involvement, then they don't know how to support that person when they're home. So that was trialled initially in mental health services, and Livewell are trialling it in adult social care. So that's kind of nationally it's being piloted. So that's like a really good way of scheme of ensuring that we involve that they're better recognised. We're working around training for raising awareness of young carers, and there's something called the No Wrong Doors, which is a memorandum of understanding, and there's lots of work going on within the city at the moment around how we work with different partners to ensure that young carers are better recognised as well, because as I said, we've got carers from the age of about 2 or 3 up until young carers definition is up to the age of 17. So we've got additional. So there's a biannual national statutory survey, and we've put additional questions into the survey to get so that we can. So when the results come, we'll get better insight and better understanding around the views of carers. Early identification also around how do we link, and because there are our carer communities that don't come into contact with services so much. So we're working with some of our colleagues, certainly within the council, and also some of the smaller other organisations about how we have better links with refugee asylum seekers and Gypsy and Roma traveller communities as well. So there's work going on around there. And then we're working with employers as well. So a lot of people, as I said, those figures, age 45 to 65, people are often working at that age, and so we've got membership or something for employers for carers, and it's around giving toolkits to employers so that they know how to better how they can be a better employer and understand the needs of who carers in their workforce. So we've been promoting that kind of broadly. So just going on to number 5, I'm so conscious of the time. So yeah, just some of the work, some of the achievements we've been doing around ensuring key information and communication. So the young carers were part of the MOU. The young carers are working with the DWP because people at the age of, so people can be eligible for receipt of carers allowance from the age of 16. And there is a very low take up. I mean, there's not a huge number of carers at the age of 16, but there's been work being doing with the DWP about how do we ensure that partners, that young carers are aware of that. How do they know? How can we best make resources kind of attractive and known to young people? So there's some work going on around there. And then Victor mentioned about the Bridget Care app, which we're working on and we're going to be launching fully soon. And that's really got some really good access to like all the different information that carers might need, and that could be around their own well-being, and it can be about how they can help to support the person they're caring for. That person might have dementia, they might have motor neuron disease. It's just got all the different information, and we're aligning that with the Plymouth Online Directory that we've been updating as well. And then priority 6 is just around when as I mentioned, when the caring role changes. So there's lots of different things that we've been looking at around, the actions that we put in the action plan, and some of the stuff that we've delivered is around collaborating with some of the local support groups, partnering with mental health and grief support groups, just to make sure. So St Luke's are one of the partners, and they're kind of leading they're leading on the delivery of this priority area, which doesn't mean to say they're responsible for everything, but they're obviously experts in that area. So there's lots of work that they're doing, linking up with existing routes. We're also working. You might have heard of the Health Determinants Research Collaborative, which is a kind of like partnership between academia and local authorities about how we try and embed research techniques into our work, and there's a work going on there around working improving the transition pathway for young carers into adulthood, and that's like looking at good practice using research techniques. So that's another achievement, and that's in progress. And then Caring for Carers now, they're extending the support to carers for 6 months after their caring journey ends. So often, when carers' journey comes to an end, they've got all of that knowledge and skills, and although they might be going through a grieving process, they often want to kind of think, well, how can I impart, how can I support other carers? And so that's a really good progress. And then also like the Connect to Work, I think Victor mentioned, that's another, some of the action points will come under more than one priority. So we try and link up that work. So like the Connect to Work as well, often when a carer, their caring journey, and they might think, well, I want to get back into the workforce, I haven't, and they might, feel they haven't got a lot of confidence because they've been out of it for a long time. So there's different work we're linking in with that. So that's just, I think that's just, we just wanted to kind of highlight some of the work that some of the achievements that we've done. It's obviously the first year of delivery of the strategy, and then I think, like lastly and very, very importantly, how do we know we're making a difference? So we've obviously done a lot of work in creating the strategy. We're implementing it, but how do we know that that's actually helping what we've delivered? So there are different mechanisms that we've identified to help us doing that. So that will include quantitative and qualitative measures. So in the action plan, against each outcome, against each objective, we've identified outcome measures, and so those might be, like we might look at, we want to see an increase in the number of carers in our carers register. We might want to look at the response times improving. So we're in the process, we've done some of the delivery, so now we're in the process of looking to see how we can measure the impact. It will include things like looking at, so for example, the Caring for Carer service, they can like observe carers and about, looking for improvements in their physical and mental health through check-ins. I mentioned carers identified, and then looking at the measuring of participation of carers in community activities, or has there been an increase in that? What kind of policies are we changing as a result of getting improved feedback, etc. And then lastly, one of the things just to mention is I mentioned the Health Determinants Research Collaborative. So we've got 2 projects at the moment around unpaid carers. So one of them is around the young carers and transition, and another one is we're working with them to help us to evaluate the implementation of the strategy. So that's kind of quite early stages, but they're helping us to sort of think about our evaluation framework and how we can use some of the kind of like methodology that we're focusing on certain areas, but how can we kind of spread the recommendations and the methodologies more broadly in the evaluation framework. So there's a few different methods there. So I think that's kind of it from our perspective. I know it's a lot of information to take in. So I don't know if you've got any questions.
Yeah, thanks, Kate, Mark, Victor. Hand back.
Sorry, can I just have clarification? If you're drawing a state pension, that you can't have a carer's allowance, is that correct?
I will have to, yeah. Once you reach pensionable age, it will become, if you apply, it will become attendance allowance. So there is a version available, but we'll double check that and report back because we need to check with qualified benefits advisors. But it doesn't become carers allowance; it becomes attendance allowance.
So what's the difference?
the name and the amount, I would.
So you're probably going to get very little if that's the case. So they might call it an attendance allowance, but it's going to be very.
It's less, yes.
Which is quite shocking, really, when you probably think the amount of people that are probably on state pension are probably the ones that are going to be the most that are carers.
Yeah.
So
that's one of the reasons that we're trying to push the income maximisation part of this, because we recognise that even the carers' benefits are not the best. So what we are trying to do is support everybody that we can to maximise as much information as we can. The next phase that we're trying to look at the lift information as well that Public Health are using around the low incomes family tracker, to see if we can identify carers through there as well to help them with low income. So yes. The benefits available are poor. Unfortunately, that's out of our control, but we are doing what we can to support our carers to access what they can.
So can I just in my head, it says it stipulates state pension. So if I was not drawing my state pension, but I had a private pension, would I still be able to get a carer's allowance?
I will need to double check that with the benefits advisors. I'm not a benefit advisor.
I'm just wondering because it does say state pension. It doesn't say anything about a private pension. So I just need clarification whether, because if I had a private pension, I might defer my state pension because I could get a carer's allowance. That's what I'm trying to get at.
Victor, could you take that back?
Yes,
and we'll clear that question up, get an answer and report back to you.
Okay, and what I'd like to do is, as a recommendation, Elliot, is that actually we write to the government to say, actually, this isn't right, this isn't fair. So if we can put something together for a recommendation, I think we should be doing that. Does everybody go? Sorry, I'm just in my head. I'm just like, I mean, I don't know what other members think about that, but I think it's not right that anybody that's drawn a pension is not being able to get a carer's allowance. That doesn't make sense. And it is, with all due respect, it's not a huge amount of money that you're getting as a carer anyway, carer's allowance. So to say that if you've drawn a state pension, you can't draw that, that's well, it seems shocking to me, but anyways, sorry.
Could I ask a quick question?
Yeah, carers allowance is one of the lowest welfare benefits. It's about £83 a week, so it's very low, unfortunately. Yes.
Carol.
I just wanted to ask a question about, I did notice the Carer Money Matters programme. That sounds really good. But I just wonder, is that capped at how many hours a week you are caring, a bit like the carers allowance? So at the moment on the census, 44% of people are carrying up to 19 hours a week. They don't qualify for carers allowance. Carers allowance is capped at 35 hours per week. Is your money programme capped at certain hours?
No, there is no limit.
There's no limit.
Anyone under the umbrella of the unpaid carer can access the service.
That's good, brilliant, thank you.
I've got Ray.
It's good to hear that there's some support starting for carers now, who are quite often forgotten about. Nobody remembers. People forget to ask carers how they're doing under a lot of pressure, an extreme amount of pressure sometimes, more so than the patient sometimes. Could you tell me how you calculate how many young carers there are, please?
So that's done by, so my colleague Colina is the Young Carers Lead, but so there's a census that is carried out within schools. So we have someone that works within the council who works in the kind of in the SEND department, and one of his main kind of duties is to liaise with carers leads that are in all the schools. And so so they carry out a census, and that's kind of like the main way that they kind of determine the number of young carers. And then obviously through social care, so there's a duty around identification of young carers that might come through the social care. So they might have come under the radar in the schools, but there's other ways that they might be known, and that would be through children's social care.
Yeah, what I would add to that is, particularly with children's social care, that we have or identify a lot of sibling carers. So that's children and young people who are helping to care for brothers and sisters. So those are quite often picked up by the social workers or the family support workers who are working with those families, who will identify those young people who are taking on a caring role, which is how we've managed to boost the numbers to, or I think it's around 1,300 at the moment that we've got identified. A lot of the issue is the young carers won't self-identify in school because they're worried about singled out or differences. That is changing quite a bit, and we've seen numbers increasing through that census survey. But that's also why we have support services offered outside of school, which is why we do a lot with the youth service and with the Children's Society, because it's taking it away from that school. So at school they can just be a pupil at the school, but we recognise there's additional burdens that they carry as a young carer. So the support is available outside of the school to help them manage and cope with that, and just to let their hair down and have a bit of fun.
Sorry, can I just add? We've also done some work around with primary care and secondary care. So their duty should also be recognising young and adult carers in that scenario. And we have done some carers raising awareness within those functions to help them understand who carers are and such, and how to identify them and what to do in terms of support functions.
Alison.
Thank you. How are we defining kind of what a carer is? We're talking about a child aged two or three, carrying out, tasks. Sort of thinking about that. When are we sort of, I'm considering that child's own needs. When does that become a safeguarding concern? I'm a granny of a 3-year-old. I've got a little granddaughter, and it just doesn't bear thinking about. I can't picture this. A child that young, as a carer, what is that child doing to make them a carer?
Yeah.
It's probably quite a big question.
It is a big question, and I think the way we would define the answer is where that young person, young person, is being asked and required to do anything that's above and beyond what a child would normally do at that age. So we are talking about 2 and 3-year-olds who might be fetching medication for mum who's stuck in a wheelchair, which you wouldn't expect a normal 2-year-old to do. So, and that is where we would look to social workers now to help identify those young carers, and sort of help identify those needs. But it really does depend on the situation and what's being asked of the young person or that child. So when we talk about children 2 and 3 being classed as carers, what we're saying is they're being asked to do a little bit more normally than when any other child would be asked to do at that age. So if it's particularly like a sibling carer, it might be helping to support with changing, which wouldn't normally be done. So if they've got a disabled baby in the family, they might be fetching nappies and that sort of thing, whereas normally you would do it yourself. But because you've got to tend or look after a very sick baby, the sibling would be asked to help out in that a bit more than what you would normally expect.
Chair, can I also say that, of course, what happens then is they probably can't go to nursery school, they can't go to playgroups, they can't do this, that and the other. So that's how a youngster may well just be disadvantaged, shall we say, and that's why we need to keep an eye on it.
Lauren?
Thank you, Chair, and thank you for the presentation. I think unpaid carers are doing really fantastic work, and I really appreciate all the work that you're doing to support them. My question is around early identification. It seems like that is the key thing to get right here, to make sure that people who are carrying out care duties, I was just reading that apparently it takes a carer 2 years to realise that's the kind of duties that they are undertaking. And in that process, missing out on a huge amount of wraparound care support and potentially £8,500 if they are eligible for carers allowance. So what kind of work and what kind of trackable work are we doing to catch people earlier in that pipeline? And kind of moving forward with this report, because I think it's brilliant, it's really comprehensive. What are we doing to kind of assess where we are now, and then in 6 months, 12 months time, say what progress has been made to help us kind of move forward on it? And wondering whether you guys can come back to Scrutiny to report back on that excellent work when it feels like a good opportunity for you to do so.
Part of the work that we're doing at the moment is we've just done a review on how carers is governed. So we talked about the Children and Young People's Carers Strategic Partnership Board. We're putting a layer in between that around management, if you like, of those work streams. And within that, we're producing our KPIs so we can set our baseline to look at and track better. So we're producing the KPIs in that. But some of the ones that we are doing already are looking at the numbers of carers on our carers register. So improving us Plymouth hold a register of all the carers that we've got known. So we're looking to make sure that that is increasing. And what we're doing to identify carers early, I mean, we do something every year with National Carers Day. This year we did that poster campaign, didn't we, where we had regular people saying, as well as being a carer, I'm an art critic, I'm a mum, I do this, and I enjoy that. So it was just trying to put posters up and visuals of helping people to recognise that they're doing other stuff on what they normally do. So we tend to do a lot of that as part of national campaigns rather than just trying to do something locally, because it becomes a national driver that we've got resources and everything to help us with.
Sorry, can I just add? So within our service, so just to give you an overview, we recently completed a 2-year project specifically working with primary care and all of the PCNs across Plymouth to help them become more carer friendly. And you know, part of that was all around the early identification and the type of support that carers can access. You know, and we do this kind of as much as we can within local sort of systems. You know, try to embed carers across, you know, whether it's primary care, secondary care, other services, and so forth. You know, and as Mark has said, we also obviously take part in the sort of more national events that happen, Carers Week, Carers Rights Day, Young Carers Action Day, and so forth. And we also deliver carers awareness training that we do for local businesses and local services to help them understand who carers are, how to support them, how they can you know, provide their early identification and the type of support carers may access if they want to. So that kind of work is taking place as we speak, and you know, we are trying to embed that across Plymouth.
And then just so, you know, just to add as well, we also mentioned this thing called the Bridget app. So we're looking at we're going to be implementing a digital tool as well. So the kind of like the purpose of that is so that there'll be support available via this app, because it's kind of based on AI, but it's fantastic, you know, product. And when we launch that, so that will go out to all of the different partners. There'll be like there'll be a launch through all the local media, through our different partners, wellbeing hubs, libraries, etc. And we're hoping that will also raise awareness and reach more carers that might not necessarily go to the service, because I mean, we've got 9,000 carers on the register. So the service, there's only so many that they can support. And if you think we've got 23,000 on the census, so we can't support everyone. But if we can put things in place like digital tools, and then people can look at them and they can get support that way, so that they're not necessarily reliant. And we will be tracking the numbers as well. So, and there are various other kind of measures that we're putting into the strategy, so that we can look at the benefits of what we've implemented.
Is there any more questions? No? Thank you all very much. I mean, it was quite interesting to read what you've put there. So the recommendation is to endorse a strategy and ongoing activity to support unpaid carers in Plymouth, and I'm sure all of this committee will support that. So thank you all very, very much, and it'll be lovely to see maybe in 6 months, see what the progress is like. You know, let's see how we go. All right. If there's anything that we can do to help, then please just let us know. Thank you. Thank you. Item 10, Armed Forces Care. Right. What I'm going to say is, this is the second time that I've asked for this to come to this scrutiny. And once again, I'm really disappointed and angry, if I'm being totally honest, because the first time I asked for information, and the what I've received was what they're meant to do, what GPs and the NHS are meant to do, not what they actually were doing. So this time, we did stress. We wanted to know what you're actually doing. I'm disappointed in the fact that nobody has actually bothered to turn up today to present this report. And if I'm being totally honest, it's not even a report. This is just something that they've got off the internet. It's not actually what's happening in Plymouth. So if I'm being totally honest, this isn't worth the paper that it's written on for me. This is not what I've asked for. And then if we go to the back of the report, and you read what was written in an email, and it says, in terms of the Armed Forces current waiting times in the Plymouth area, below tables, there are no special provisions for the population to be seen faster than the rest of the population. That is actually untrue. If they understood the Armed Forces Covenant, which I have got a copy here because I did just wanted to make sure that I knew that that was absolutely right. But the Armed Forces, yes, serving personnel, veterans and their families are entitled to priority NHS treatment for conditions related to their service under the Armed Forces Covenant, subject to clinical need. They do not jump the queue over patients with higher, more urgent clinical requirements, but receive faster access for service-related injuries. So conditions, the priority applies to illnesses or injuries caused by their time in service. Veterans receive priority treatment for conditions relating to their service. So I am really, really disappointed because if you've had a look at that, and plus we only received it yesterday, this isn't talking about Plymouth. This is just a general. So I'm not going to do anything with that. What I will suggest is maybe we make a recommendation that we write to the Minister of Defence to maybe get him to write a letter to the NHS and whoever to remind them or to enforce that they understand the Armed Forces Covenant and what it implies, because this is absolutely disgusting. And if I'm being totally honest, I am going to get them, I'm going to ask for this to go on the March meeting once again, and that we do have somebody from the ICB and maybe NHS here so that they can deliver a proper report to us of what they're actually doing, because this is just not acceptable in my eyes. So I hope that members will actually support me in what I'm saying here, because I'm just devastated that once again this is what we've been given. So that's all I'm going to say on the matter. I don't know if any members want to say anything. You don't have to, but if you want to, you can. If not, I'm going to move. Ray.
It was interesting to hear what Kev Sproston had to say yesterday on the subject, and I'm quite familiar with it too, because I used to have to type the medical reports up before I sent them to Derriford years ago. So, yeah, it's not well represented for today at all whatsoever.
Right, that's all I'm going to say on this one. There is no point. Oh, Andy, sorry.
Pauline, I was just going to reiterate exactly what you said. And actually, if you ask for it to be specific to the city, why give a generalised report? I mean, it's just a waste of everyone's time, this being on the agenda, if we don't have a specific report which is applicable to this board. So, yes, I'll support the recommendation.
Thank you. That's all I'm going to say on it. As you're probably aware, I'm probably very passionate about our armed forces, and this was just not acceptable. So, anyways, we're going to move on now to item 11, which is the action log. So it's over to you, Elliot.
Thank you, Chair. I'll keep this one relatively short and sweet. Members will note that in relation to the first, second, third action, which come under minute 104 on your log, I've circulated by email on the 23rd an update. Most of that relates to the performance report, and you've also got printed copies in front of you today. The second action related to an update on vaccination uptake in care homes and across staff. So winter planning evaluation item, I'm going to suggest we put in for March to fully review how the winter plan performed, as they gave an interim update today. It would make sense to bring back in March and look at how all systems performed. The third is minute 106, and that was agreed to receive an update on progress within the Building Brilliance programme. That was obviously relating to readmissions, which we had at the last meeting. They're on an improvement sort of strategy or programme, so it probably would make sense to look to see if that can come back in March, if not the first session in the new year. And then the minute 96 marked as complete is obviously the site visit to UHP with photos attached for evidence. And then the bottom one is the Select Committee on Transitions, which is currently scheduled for the 24th of February with Children's as a joint scrutiny. Thank you, Chair.
Thank you, Elliot. And now we're going to go to item 12, the work programme. As you can see, I need to talk to you before we go to that. It's been scheduled to move to the 5th of March, but I understand there's 3 members of this committee that sit on taxi licensing that actually are meeting on the same day. So the option is because I think, if I'm being totally honest, to try and find 3 subs is probably going to be a little bit difficult. So the option is that we have to move this one to a different date. So I don't know what your thoughts are on this, members. So yeah, Will.
I don't mind moving, but if there's a time clash, could we go in the morning, or is that an all day thing?
Taxi licensing normally goes on all day because it used to be just the morning, and then
but
now apparently it does go on all day because of Uber and all of that sort of stuff.
If
So
it's got to move, it's a different day. That's fine.
I know it's difficult for people that do work because obviously you've probably already put something in your diary, but I need from the members themselves. I'll go with whatever the members decide themselves. Yes.
Through you, Chair, thank you. I'll just briefly explain that meeting was put back because we had a delay to one of our earlier meetings, and then it was going to be like within a week of the next one. So the one scheduled for the 5th of March was originally the 3rd of February. Was moved to the 5th of March in the hope that taxis would finish within a few hours like it used to. Obviously, that's no longer the precedent. Looking in the diary, essentially, you've got, after the scheduled meeting on the 5th of March, just over a week before pre-election period, so just over a week we could move it backwards. There's the Friday the 6th, which currently looks free. Monday is Cabinet, Tuesday is Audit, Wednesday the 11th evening is Scrutiny Management Board, and 12th is Health and Wellbeing Board. So I'd probably suggest either Friday the 5th or Wednesday the 11th, but happy to put that in an email to members and do a bit of a poll as to what's more accessible. Not in the diary.
Elliot, could we go Wednesday the 4th?
That currently looks clear. I just have to check the room diary, Chair. Subject to me kindly asking someone to leave the room, we could do Wednesday the 4th, Chair.
Is everybody happy with Wednesday the 4th? Because then we can get it straight in there now, so that we got room booked in. We've got people in the ear that we need to have. Is that all right with everybody? Yeah. Sorry? Yeah, it would be normal time. Is that okay? Or unless anybody wanted a different time, we could maybe do it earlier if that helps anybody. It doesn't matter to anybody, or sorry? But yeah. Is 2 to 5 all right with you? Yeah, so we'll do 2 to 5 like we normally do then. Is that all right, Elliot? Yeah.
Thank you, Chair. So I will take that as our date of choice. There is something in the diary that I have to move first. I'm not quite sure how significant it is, but it's not one of our sort of board meetings. So yes, subject to me agreeing with them to find an alternative place.
We not all of them use the chamber. We could use the chamber, or they use the chamber.
We'll figure out.
Yeah. Okay. So back to the work programme. So we've got that. On it, we've got already ICB reforms and restructures update, Plymouth Suicide Prevention Strategy Partnership Action Plan 2024-26. Does anybody else want any? I mean, we're going to put the Armed Forces back on, Armed Forces Care back on. Is there anybody else that wanted or desperately needs anything put on that agenda? Mary?
Chair, I think it would be useful to find out more about EPIC and whether you've got the luxury of time for the new year, should we say, or I thought they were in getting it on track and operational from June or July. I think it was July, they said. So I don't know when the first one is in the next calendar. If you've got that to hand, Elliot. I mean, if we all know that it was published yesterday, so I mean, in theory it is, and you know, I think it's more an information thing, because certainly it will affect how the discharges are done and stuff like that, which exactly. Yeah. Yeah.
Through you, Chair, just to say our first provisional meeting for the new municipal year would be the 14th of July. So I'll look into how that ties in with EPIC timelines. It could be that we need to do it in March.
I've got a sneaky feeling Exeter might even be starting it now already. Yeah.
Right, so are members happy for myself, Carol, Elliot and Gary and Mary and whoever to sort out the next agenda for the next meeting? Yeah, yeah. If members at some point want something specific put onto an agenda, you just need to email us. I think, you know, I do ask every time after a meeting if there's anything particularly want on, but you might go away and then something crops up and then you might, oh, actually, I wouldn't mind having that put on the agenda. So we're always open to anything that you'd suggest. So I think that is it, isn't it? can I just thank you all once again for attending the meeting, and I'll see you again soon. Thank you very much. Thank you.